One thing that's really quite difficult to do when we're doing a video consultation is to examine a patient's range of motion, because we're used to having two hands on the patient, guiding their movements. Examination of passive range of motion always comes first. But this is a good trick. I call it the Charleston dance test. So Daniel, if you can put your hands on the chair, please, and keep your knees facing forwards, and just bring your one foot out to the side as much as you can. Okay, and relax. And you can see Daniel's twisting slightly in the chair, and this is quite typical of video consultations. The patients will do things slightly differently, and it's difficult to guide them, and patience and just going with what they do is really key. So Daniel, can I ask you to sit back in the chair for me? Shuffle all the way back and keep your knees facing the front and sit straight. And now just bring your foot out to the side. Great. And bring it back to the front. And now can you do it with both feet out to the side? Okay, great. And back to the front. And so you can examine for the range of motion of internal rotation. And loss of internal rotation, as we know, is the earliest sign of hip arthritis. And so this really useful finding can be replicated even when you're not in the room. And you can look at the range of internal rotation and the symmetry of internal rotation, both sides. I can ask you to stand up, Daniel. Another useful thing is to go on tiptoe. Great. And stand on your heels. Okay, great. And so that's a really good sign. And stand straight. That's a really good sign of if there is nerve pathology. So hip and spinal pain are often confused. Pain in the buttock very frequently is sciatica, but it can be arising from hip arthritis. And sciatica with pain radiating down to the foot, into the foot, neurological signs, it's not always that clear cut. And pain radiating to the knee can be coming from hip arthritis. So it's quite rewarding to be able to differentiate the two with a video consultation. Okay, Daniel, if I can ask you now to lie down on the couch for me. And this is an ordinary sofa, just as a patient would have at home, not an examination couch, but it's surprising you can get quite a lot of information in this way. So Daniel, I'm going to ask you to actually shuffle to the edge of the couch for me. Not right to the edge, but just more to the edge so I can see you really clearly. Yeah, a little bit more for me. Great. And now with your left leg, if you can bend the knee for me and hold the front of the leg and bring the knee into the chest. Great. And you can see Daniel's left leg is also, his right leg, his right knee is also bending slightly. And relax for me. And so this replicates Thomas's test for fixed flexion deformity of the hip. And in a patient who is able to bring their knee all the way into the chest and able to push the other leg down, you can have some confidence that both hips are quite supple. Even though the couch is soft, even though a lot of spinal movement will accommodate some stiffness of the hip, the most useful thing is if they're not able to push the leg down, that indicates significant pathology. And so you can look at range of motion quite effectively in terms of the most useful measures, which are fixed flexion deformity, flexion range, and internal rotation of the hip.